Okay. You know, medicine is a fascinating field. One symptom, like a simple rash, can unlock an entire puzzle of interconnected systems, pointing us toward a diagnosis that changes a patient's life. Today, we are going to exactly that. Welcome to our case discussion. We are Group 1. We are going to break this case down. Let's dive in. Sneha, set the stage for us. Who is our patient and what brings her in?
We have a 35-year-old female presenting with facial rash and intermittent joint pain for the past 3 months.
Facial rash and joint pain, that's already raised red flag for an autoimmune process. But let's not jump into conclusion yet.
Let's break this down. 3 months ago, she developed a red rash across her cheeks and nose, which worsened with sun exposure. That's a big clue.
And she has intermittent joint swelling and her stiffness in her wrists and knees. Worse in the morning but improve with movement. That sounds inflammatory to me.
2 months ago, she also started experiencing intermittent headaches and fatigue. And here's the twist. She reports facial flushing triggered by hot beverages, spicy food, and emotional stress.
So we are dealing with a rash, joint pain, fatigue, and flushing. Could this be SLE, or else we are looking at something else like Rosacea?
Her past medical history is unremarkable and no known autoimmune disease, no chronic illness, and no history of allergies.
But family history is interesting. Her mother has rheumatoid arthritis, and her maternal aunt has systemic lupus erythematosus that increases her genetic predisposition.
Good point. And socially, she works indoor as an accountant but enjoys outdoor activities. Sun exposure could be relevant if we are discussing lupus. Guru, walk us through her exam findings.
Her vitals are stable, but what stands out is her skin. She has a well-demarcated erythematous rash across the malar area, sparing the nasolabial folds.
And joint-wise, she had mild swelling and tenderness in her wrist and knees, but no deformities. That's more in the line with the lupus rather than rheumatoid arthritis, which typically cause erosive changes over time.
No ulcers, no telangiectasis, normal cardiovascular and respiratory exams, neurologically intact.
Let's go to the labs. Her CBC shows anemia and borderline low WBC count. That could indicate an immune-mediated process.
Her ESR is elevated at 40 mm per hour and CRP is mildly elevated at 8 mg per liter. So there is definitely some inflammation.
And here is a big one. ANA is positive at 1:6 with a homogeneous pattern.
That's highly sensitive for lupus, but let's not forget other condition can also have a positive ANA. What about the more specific markers?
Her anti-dsDNA and anti-Smith antibodies are negative, which might indicate a milder form of SLE or another immune conditions. But her complement levels are normal, making severe systemic lupus less likely.
Urine analysis is clear. No proteinuria or hematuria, suggesting no significant renal involvement at this stage.
And both dermoscopy and Woods lab findings make rosacea or an infectious cause unlikely.
So at this point, what's our leading suspicion?
Autoimmune disease, most likely SLE, given the malar rash, intermittent joint pain, fatigue, and positive ANA.
But we still need to rule out differentiations.
Rosacea, flushing supports it, but no telangiectasis or pustules and systemic symptoms don't fit.
Dermatomyositis could cause a rash and fatigue, but no muscle weakness or Gordon's papules.
Rheumatoid arthritis, joint pain, morning stiffness, easing with movement, and the family history is there. But lupus symptoms is dominating, and the malar rash isn't typical for rheumatoid arthritis.
So based on the SLICC or ACR Euler criteria, we are diagnosing her with SLE.
Lupus is an autoimmune disorder driven by genetic and environmental factors. Antibodies attack normal tissues, forming immune complex that trigger inflammation and damage.
And it's a complement activation and cytokine release that lead to tissue injury over time.
Rash in SLE spares nasolabial folds, whereas in rosacea it doesn't. Sunlight could be triggered for SLE, whereas rosacea has other triggers like spicy foods, emotions, and alcohol.
Telangiectasia and pustules are usually present in rosacea. Joint pain and systemic symptoms are seen in SLE. ANA antibody is sensitive for SLE.
What else do we need to ask to confirm the diagnosis? Does the rash come and go? Any other skin changes or muscle weakness? History of chest pain or numbness in extremities? Any miscarriage or blood clot history to assess APL syndrome risk.
So we noticed that our patient experiences facial flushing. What are we thinking?
Flushing makes us consider rosacea, especially since it's triggered by hot beverages, spicy food, and emotional stress. But
Rosacea alone wouldn't explain her joint pain, fatigue, and positive ANE. It's a clue, but not the whole picture.
Exactly. The overall clinical picture, malar rash, systemic symptoms, and antibody findings strongly favors SLE.
All right, let's analyze her antibody results. Sneha, break it down for us.
her ANA is positive at 1:640 with a homogeneous pattern that's significant because ANA is positive in over 95% of SLE cases.
High antinuclear antibodies titer with homogeneous pattern suggesting antibody against chromatin, histones, and anti-double-stranded DNA, which are commonly seen in lupus.
But here's the catch. Her anti-dsDNA and anti-Smith antibodies are negative. These are highly specific for SLE, but not all lupus patients have them.
So, a negative result does not rule out SLE. Instead, it suggests she may have a milder or early stage form with a lower risk of lupus nephritis.
Great. Now, what additional tests should be run to get a clearer picture?
We should expand our antibody panel, checking for anti-RO, anti-LA, and anti-phospholipid antibodies. This can help us identify subtypes and complications of lupus.
Renal function tests like serum creatinine and EGFR are crucial. If lupus nephritis is present, we need to catch it early.
And given her fatigue, let's go liver function test to rule out any hepatic involvement.
We should also consider a chest X-ray and pulmonary function test, since lupus can cause pleuritis, interstitial lung disease.
Finally, a skin biopsy could help if there is any uncertainty about a rash being lupus related or any other dermatological condition.
If the skin biopsy is inclusive, does that change our diagnosis?
Not really. SLE is a clinical diagnosis and the systemic features support it.
So we proceed with treatment based on severity. Niacids and hydroxychloroquine for mild cases, steroids or biologics is if needed.
If it's rosacea, we'd focus on avoiding triggers, skin cares, and topical metronidazole or oral tetracyclines.
Her normal C3 and C4 levels suggest no severe immune complex deposition yet. Absence of hematuria and proteinuria show no kidney involvement either.
But if she later develops hypertension and proteinuria, we did suspect lupus nephritis.
Lupus nephritis immune complex depositions in the glomerulus leads to inflammation, causing proteinuria and secondary hypertension.
Right. And to confirm the type and severity, a kidney biopsy is essential. The biopsy finding will guide our treatment strategy.
Once lupus nephritis is confirmed, we initiate induction therapy. First-line options include mycophenolate mofetil or cyclophosphamide. If you choose cyclophosphamide, leuprolide is given beforehand to protect brain function.
A combination of tacrolimus, mycophenolate mofetil, and glucocorticoids is another option, especially in certain ethnic groups.
And after induction therapy, we switch to maintenance therapy to prevent relapse. This typically includes MMF or azathioprine.
Besides immunosuppressive therapy, supportive management is crucial. ACE inhibitors or ARB could help us to control blood pressure and reduce proteinuria.
And importantly, avoid niacids. They are worsen kidney functions in lupus nephritis patients.
So, our important clinical takeaways: a rash and a joint pain in a young woman, we consider lupus.
ANA is sensitive but not specific. Look at the whole picture.
Lupus nephritis is a major cause of morbidity. Watch for proteinuria.
Rosacea can mimic lupus, but systemic symptoms are the key differentiator.
Malar flush is seen in mitral stenosis, whereas malar rash is seen in SLE. And that brings us to the end of our case discussion. We hope this journey through clinical reasoning helped you appreciate how we approach complex cases in real life. Thank you.